So thank you to everybody for being on with us tonight from all over the country, and it looks like maybe even all over the world, a few people. This is a really important topic that's near and dear to all of our hearts here on the panel, talking about that transition from pediatric to adulthood in epilepsy and all of the considerations to think about. We've got some wonderful panelists for you tonight, and we're really excited to share with you. They'll each be introduced as their topic comes up, so I won't do all the intros right now, but we are going to have some information about Social Security, about guardianships, about medical care, and some really great info from moms who've been through that process of transitioning from pediatric to adult care. I'm Carrie Jones. I'm the Executive Director for Epilepsy Advocacy Network, and we are the member organization of Epilepsy Alliance America that serves Central and Northwest Illinois. With me, I've got Erica, if you want to do your quick intro.
Hi, I'm Erica Fleck. I'm the founding director of Epilepsy Services. I've been in this field for a long time, and I'm an advocate, and I like to talk about epilepsy and spread education and awareness because I was that person who struggled with epilepsy.
And
Thank you for everyone coming.
Yes, we're very happy to have this opportunity with Epilepsy Alliance America tonight. And so we just wanted to say once more, so everyone's aware, this is going to be recorded. We do want to point out the Q&A box that should be at the bottom of your screen, your Zoom screen. The chat is great for sharing where you're from or just some general thoughts as we're going through. But if you have a specific question for one of the panelists, please do put that in the Q&A so we don't miss it and that we can get to it at the end. So questions will be mostly held till the end. We might be able to answer a few of them in the chat or in that Q&A box, but we will have all the panelists come back up after we finish with their presentations, and you'll have the opportunity to have their questions answered live by our wonderful speakers. So without further ado, I'm going to have Erica do our intro to Dr. Issa, and we're going to kick it off.
We have Dr. Issa. He is from the University of Chicago. He is an epileptologist, which is a neurologist who specializes in epilepsy. He's a great resource for the EAN and our participants, and we're just very happy to have him here tonight. So thank you very much, Dr. Issa.
Excited to be here. Thank you for the invitation. Hi, my name is Norm Issa from the University of Chicago Comprehensive Epilepsy Center, and I'm very grateful to both Erica and Kari from the Epilepsy Advocacy Network for letting me talk about this important topic, specifically the transition of care from pediatric to adult epilepsy care. You know, there are lots of perspectives on this, but I think the most important perspective really is twofold. One is you're talking about a transition from one care group, the pediatric team, to an adult care group that has different teams, different approaches, and even different waiting rooms where the feeling is completely different. But I think the more important perspective really is the transition from going from parent-guided care to self-guided care for this young adult. And so that's a transition that has to be planned out. And I think there are very useful approaches to doing that. One of the most useful set of tools on this comes from the Child Neurology Foundation, where they've talked and planned out some of these transitional principles. And they've come up with 8 kind of common principles to help with transition of care from a pediatric to an adult environment. And we're going to go through a few of these, but I want to reference this as the main really useful source for thinking about this transition. The first thing is really when do you start planning the transition and what should you expect from it? And the answer, according to the Child Neurology Foundation, is you should start this pretty early in the early teenage years, between 12 and 14 years old. And you start sort of acclimatizing the child to the idea that they have to advocate for themselves and speak on their own behalf. And that includes having time during visits with their pediatric physician where the teen can talk without the parent present. This allows the child to have both some time where they can talk about things that they might not feel comfortable talking in front of their parents about, but really more importantly, so that they get used to advocating for themselves and talking about their own healthcare without their parents' input. I can tell you, as a parent of young adults, it's surprising sometimes where the child thinks that they have made everything clear, but they've never actually said anything to the adult. And so part of the process is letting the teenager learn how to communicate that to the caregiver or the physician team, and having that start at, in the early teen age is a good time for that. The important thing to keep in mind is that at age 18, the physician really now has to have the young adults consent before they can actually speak to the parents about their health care. So having that transition process go on is a really useful thing early on. Now, it's often the case that in situations with epilepsy and comorbidities, that a child won't actually have the decision-making capacity once they arrive at 18 years old. And so the expectation should be that all the legal processes and work that has to be done to maintain legal guardianship over that child should be done before 18 to prevent complicated transitions after that age group. The Neurology Foundation recommends that the full transition be completed by age 22, even though there are some transitionary components after 18. The second thing that they talk about is a yearly self-management assessment. And this is really talking about how a patient in their teenage years is being sort of quizzed and prompted to know their own healthcare information. So do you know your own medicines? What doses, what times do you take them? What are they called? Do you know what your allergies are? This can be very important later in life if they may not have remembered that they had a bad rash at age 7 when they started lamotrigine. But that has to be known, because at age 25, if they're now transitioning and they want to have kids, and we say, well, the safest thing for you to be on is lamotrigine, if they don't know that they had a bad allergy to lamotrigine, they'll start over and they'll have a bad reaction again. Who would you call if you have a problem? And this is really important, teaching them how to use both contact information, MyChart, telephone, and understanding the difference between sometimes the hospital, the emergency room, and their physician's office. It's also important to engage parents in this transition, making sure that the parents know whether or not their child's going to be able to make their own decisions. And if not, what are the plans so that they can continue caring for their child? Will long-term care plans be needed? So when a child is 12 or 13, often the parents are still young and healthy, but by the time the patient's reaching 26, where they may now have to transition to their own insurance or different insurance plans, is there a plan for them to be insured? Is there a plan if one or both parents get ill or are not present anymore, to make sure that young adult or even the aging adult has some long-term care plans in place? The Child Neurology Foundation has some useful checklists and tools to sort of help with that assessment, and I encourage you to look at them. The next thing that has to be discussed is not just an assessment of the patient's ability to care for themselves, but also the ability for them, an assessment of the actual medical condition and the changes that happen in that medical condition with maturation. Discussion of medical side effects, of course, discussion of how well seizures are being controlled, a discussion of sexual changes that happen with puberty and maturation. Many of these affect women more than boys, but they're important to talk about. The effects of seizures, the effects of medications on oral contraceptive pills, the safety of medications in childbearing, vitamin care, and potential either genetic components to epilepsies, but also the effect of anti-seizure medications on a baby or a fetus. Driving is a very important consideration for teenagers as they reach 16 years old. I know in the city, many children, even without epilepsy, delay driving until they're 18 or 19, but in the suburbs or other places that might not be the case. And so people are lining up at 16. So you have to have the discussion at 14 and 15. Okay, what is the effect of having seizures? What is the effect of the seizure medications on your ability to drive and get that driver's license? Alcohol and substance abuse is an important thing to talk about with all teens because almost all are going to be exposed to it in middle school or high school. But it's particularly important with epilepsy where specific medications or specific drugs can worsen seizures. Alcohol use chronically or even acutely and binge drinking can affect seizure risks. So all these things have to be discussed openly and early. Psychological well-being is an important thing during high school and middle school where stresses and interactions become very stressful, which can trigger seizures. But I also like to emphasize that epilepsy is a combination of symptoms. One of the symptoms that you can see is often seizures. The other one that you can't easily see is depression. And so depression is a very frequent comorbidity with seizures and epilepsy. And when you have the added stress of middle school or high school, that can get to be a lot. So that is something that should be discussed and actively treated if it's an active issue. The next formal thing that should be done is an evaluation of legal competency, and that should be started by the child neurology team right around 14 years of age in a discussion with the parents and caregivers to have an assessment of whether there's going to be an expected legal competency. This exam and assessment should be documented as part of the medical record. And if it's unclear whether there's going to be the ability to be legally competent at 18, this assessment should be repeated annually. Throughout the entire thing, we should hope to maximize the young adults' decision-making ability. So I don't think we should assume that they can or can't, but rather try to make it so that they have the maximum decision-making ability that they can. When it's decided that the child will probably not have legal capacity or competency to make their own decisions, the child neurology team in collaboration with social work and groups like the Advocacy network should help the caregivers develop things like legal guardianship and powers of attorney so that there's no big surprise or crush right at 18. And then kind of the final stage is identifying and making the transition to a new adult provider. And I think when you're looking for a new provider, the first thing you should really do is assess expertise. So there are some sort of very common epilepsies, juvenile myoclonic epilepsies, focal epilepsies, that can be handled by a general neurologist or an epileptologist at a level 3 center. But then there are some kinds of subspecialty, very specific epilepsies, specific genetic epilepsies, devices where things are being treated by devices that you want to make sure that there's expertise in the group that you'd be going to. Have you programmed or placed RNS devices before? Have you treated patients with specific rare genetic epilepsies, or do you have the genetic resources to help with that? I think an important consideration is insurance. If you're going to have to make a transition, you want to make sure that that provider takes the insurance so that you don't have a lot of out-of-pocket expectations or suddenly have to change at the last minute because they don't take your insurance. Location is important. I think now with video visits becoming very commonplace, it's less of a concern, but I do think that almost everybody wants to see the patient in person at least once at the beginning and then as frequently as possible, but you can have video visits. So just make sure that they can accommodate however you want to be seen. Availability is important and meeting the physician and their team to assess fit is really useful. And the final thing I want to emphasize is that it's a team approach. A lot of times the emphasis is made on, well, did we like the doctor? The doctor, I think, is very important, but the team around that doctor is important as well. When you send a message or call, the first person who's going to be looking at that message is really the nurse. And if they can answer that question quickly and efficiently, they'll probably do that even without engaging the physician. So make sure that you talk to the nurse, you feel comfortable with their communication and how they address your concerns. And then there's often an advanced practice nurse. And once your child is stable, sometimes you'll be transitioned to see the advanced practice nurse for most follow-up visits, seeing the physician only infrequently. And that's okay, really, if if everything is stable and everything's working okay. So you want to make sure that you know who those advanced practice providers are and perhaps even meet them. Finally, what are you going to bring to that very first visit? And I think this is really useful to make it a smooth transition to the new physician team. The most important thing is a summary of the case that comes from the child neurologist. It's really helpful to see what tests were done, what medications were tried, when they had the best control, and what might be the next thing to consider if control isn't perfect. If you can bring a video of the child's seizure, that's really helpful. If there are different kinds of seizures, a couple of videos are useful. Bring all the medications in bottles to see what was formally prescribed, how it's being taken. Equally useful is a history of what medications were tried in the past and why they were stopped. Or did they have an allergic reaction? Did they have bad side effects, too much weight gain, whatever? Were they ineffective? Those are useful because if we're going to make any changes in the future, we want to not repeat as many mistakes as possible from the past. A family history is very useful, and a developmental history is useful. And oftentimes, the young adult might not know these well. They don't know who in the family has had seizures as a child or at other times. They also probably don't know their developmental history. Were they born early, late, on time? Did they walk it and talk at about a year? Did they have an individual education plan during schooling, and so forth? If they've got devices, information about those devices, like when they were placed, what the programming settings are, who the representative was from the company that's been helping for like VNS, RNS, DBS, and so on. I know I like to see MRIs, original MRI data on discs. The report is crucial, but I really do like to see the MRI and have an MRI in our records. EEG reports are very useful, especially if there are multiple reports that have shown different things. It's good to see those reports. EEG on disc is a plus, but it's rarely feasible, so it's really not an expectation that we get those. If there's been genetic testing done, those results are crucial. They'll help plan out other changes and tailor management. And finally, if you have legal documents on decision-making capacity, power of attorney, things like that, those are very useful to have. There's several resources. Both American Epilepsy Society and the Child Neurology Foundation have resources, and you can either search for these or their URLs in this directly that have sort of recommendations for transitions. The Epilepsy Advocacy Network is a great resource to turn to. I know Erica has been and the other representatives have been very helpful and have a real depth of knowledge about how to navigate these things. So it's really good to have them on your side. And I look forward to taking questions. Thank you.
Thank you, Dr. Issa. Next, we will hear from Megan Forstall with the Social Security Administration on government and other benefits to consider. Thank you for being here, Megan.
Good evening. My name is Megan Forstall, and I'm a public affairs specialist for Social Security. And this evening, I'll just be going over some brief information regarding our disability programs and the application process. So at Social Security, we want you to know we are with you throughout life's journey, including when the unexpected happens. Just to start off, as far as our definition of disability, because our definition is different than some other agencies you might have familiarity with. We'll start with an adult person with a disability. That would be a person who cannot work due to a severe medical condition or combination of conditions that's expected to last at least 1 year or result in death. and this condition must prevent from substantial gainful employment. Now, substantial gainful employment, or we also call it substantial gainful activity, or SGA, that is a dollar figure every year. So when we're talking today, we're just going to be talking in 2024's figures. So for the year 2024, that definition of SGA is if it's any impairment other than Social Security's definition of blindness, then the ability to work and make $1,550 a month gross is what they're looking at when they're making a medical decision. Can the individual, despite their impairments, work and make $1,550 a month? Now, if the individual is found to be blind with Social Security's rules, that's a higher figure at $2,590 gross a month for 2024. Now, so for adults, that's as soon as someone's 18, that's what we're looking at for the definition of disability, that ability to work. But for children, we look at a different criteria. So a child is anyone under 18 that has a physical or mental impairment or combination of impairments that results in marked or severe limitation in functioning. So with this, we're looking at how a child performs relative to other children their age. So again, a child must be either blind or disabled, and they would have to meet our definition of blind for that. Now, the similarity between the two programs, between the two definitions of adult versus child, is that the disability is expected to last at least 12 months or result in death. So for Social Security disability, we're looking at a work history. For supplemental security income, we're looking at income and resources. So also for SSI, the limited income and resources, and then having that disability, unless an individual is 65 years of age or older, then they only need to meet our income and resource requirements. Now, whenever we're talking about income and resources for SSI, I like to point out that these examples on our slides are just some of the things we look at. So we're going to go through a long list of questions, and we're going to ask, are there any other income, that you have in your name or your child's name that we haven't mentioned? These are just some of the more common types of earned income and unearned income. The reason they're in two separate categories is earned income is counted differently than unearned income. As far as resources, what we're looking at, we do exclude a home, the highest valued vehicles, as long as it's used for transportation, burial plots, some other resources set aside for burial. And we have a variety of policies that cover all sorts of different resources and their exclusions, but these are, again, just the most common. And an individual, we're looking at a $2,000 resource limit. A married couple living together is $3,000. If it's two parents in a household and they're filing for the child, the two parents would have a $3,000 resource limit, and the child would have their own $2,000 resource limit. Another thing we look at to determine payment of SSI benefits is the living arrangement. So the living arrangement would not necessarily make someone ineligible or eligible for SSI payments, but it will determine how much an individual receives from SSI. What I recommend, if you want more information on SSI, is to head to ssa.gov and check out our spotlight section. So if you type in SSI spotlights in our search bar on our homepage at ssa.gov, you'll find a lot of different spotlights that get into the more specific topics you might have questions about with the SSI program. Now, anytime child is under 18, still living with any parent, whether that's a natural parent, adoptive parent, step parent, living in the household, we're going to look at the parent's income and resources as well. And that is up until age 18, and it's only the parent or parents living in the household with the child who's filing. For adults, we look at their spouse's income and resources, and we also deem that toward the individual filing. Now, if a child is not eligible for SSI because their parents' income and resources are too high, the child can file as early as the 18th birthday, and then we will no longer look at parents' income and resources. But if a child is already been on SSI, they did qualify prior to age 18, then there's a couple things that will happen at age 18. We're going to do a non-medical review of income and resources and living arrangement to see if the child who's now turning into an adult is paying toward food and shelter, and stop looking at the parents' income and resources. And we'll make a new medical determination, determine if the child meets the adult definition of disability. Now, normally you have to wait until the 18th birthday. An exception to that is SSI youth who are transitioning out of foster care at age 18. You can file within 180 days of losing foster care eligibility so that that decision can be on the way to being made before the loss of income occurs. So we do say with all these programs, it does say, we're looking at to be a long-term disability, disabled for at least, expected to be disabled for at least 12 months. But you do not have to wait 12 months after the disability starts to file. You should file if the expectation is it's long-term as soon as becoming disabled. This application, this says 3 to 5 months. I'd say it's at least 6 all the way up to 12 months for a medical decision at this time. So you do want to get that moving. The application process can be flagged as a faster process if there's certain conditions involved. You can find information about that on ssa.gov about compassionate allowances and presumptive disabilities. To apply for benefits as an adult, you can always start the process online through the Social Security application and go on to the SSI and the Adult Disability Report, or you can call our toll-free number 800-772-1213 and make an appointment. For children under 18, you do need to schedule the appointment for the income and resource part. There's nothing available online for that for SSI, but you can do the child disability report online, which is the medical and school information. Once the application is received, it's going to be forwarded to the Disability Determination Service. They're going to review the medical records, maybe send a request for you to go see a doctor contracted by Social Security, and send out potentially more paperwork for you to complete. If it's selected as a presumptive disability, which is one of those I mentioned you can find online, sometimes we can begin payments right away while we're still waiting on a decision. And there is a list of those conditions available on our site. Once the Disability Determination Service has reviewed everything and made their decision, we're going to tell you about the decision either with a letter that says you've been awarded, or a denial letter that says you've been denied and tells you about your rights to appeal. Or with SSI, we often need to call you and go through information first before we can start the payment if awarded. So in that case, the local office will reach out. It's really important that you file an appeal if you disagree with that medical decision within 60 days. It protects you for payment purposes, protects you for back pay. So you want to follow through with that appeal rather than making a new application down the road. And you can find, of course, all this information on ssa.gov, our website. If you need to deal with your field office locally, we also have a field office locator, and I'm looking forward to answering any questions you have later on this evening.
Thank you, Megan. Next up is Mike Gulo, attorney at MG Gulo and Associates. He will be sharing about guardianship of your adult child. Welcome, Mike. Thank you for being here.
Hello, everyone. My name is Mike Gulo, and I'm an attorney in Streator, Illinois. And first of all, I'd like to thank Erica and Carrie and the Epilepsy Network, Epilepsy Advocacy Network, for inviting me to join you tonight. And as I indicated, I'm an attorney in Streator, Illinois. Streator is about 100 miles southwest of Chicago. I tell people we're out in the middle of the cornfields. Streator's a small town with probably about 12 or 13,000 in it. And I think probably just as importantly for this meeting is that I am also the parent of a child with a disability who has epilepsy. My son Jonathan is now 39 years of age, and he's had a vagal nerve stimulator put in. He's had a brain surgery, and I don't know how many different anticonvulsants he's taken, but even with all that, he still has surgery. And because of his, situation, that's when I got involved in doing estate planning for parents, of children with disabilities. And it can be any disability. It doesn't necessarily have to be epilepsy, but obviously, some of my clients do have children with epilepsy. So when I work with parents of children with disabilities, there's really two areas that we're working on and trying to protect, okay? One would be protecting the benefits that that child receives, because I'm sure, as most of you know, the benefits that a lot of people with disabilities receive are things like SSI, which is supplemental security income. They may also be getting Medicaid, to pay their medical bills. Sometimes in Illinois, we have what we call DOORS assistance, it's Department of Rehabilitative Services, and they provide, services for around the home, kind of day services type things. Also, we'd be talking about food stamps. So we want to be able to make sure that we protect those benefits for the child with a disability, okay? And the other thing that I'm usually working on is, to make sure that the child is protected. And we usually do that through what we call a guardianship proceeding, though there are a couple of, there are some alternatives to a guardianship, and I'll talk to you about that. Also, in some states, guardianships are called conservatorships. In Illinois, we call them guardianships, so I'll probably use that name. But in other states, I know they call them conservatorships, where their parents are trying to go into court and become the conservator of their parent. I am also a member of the Special Needs Alliance, and the Special Needs Alliance, and write that name down, Special Needs Alliance. We're a national group of attorneys, and the attorneys in that group sort of specialize in helping parents with children with disabilities. So you can go to their website, and a lot of the information that I'm going to be giving you will be on their website. They have an attorney, I think, in every state in the United States. We recently got an attorney in Iowa. I think that was the last place we weren't in. But the Special Needs Alliance can be very helpful to you as far as finding an attorney and some of the things you need to know as a parent of a child with disability. So like I say, when we're talking about special needs trust, so what a special needs trust is it's a trust that can hold money for the benefit of a child with a disability, but the assets in that trust are not held against that disabled beneficiary in determining their eligibility for SSI, Medicaid, benefits that might have asset and income limitations, okay? And there are a couple of different types of special needs trust. Usually when I'm working with parents, we're doing what we call third-party special needs trust. And third-party special needs trust mean that the money going into that trust comes from a third party. Typically, it's going to come from the parents, as far as their estate plan is concerned. Mom and dad are going to say, well, if dad dies, everything's mom. If mom dies, everything's dad. But then upon the death of the last of them, there'd be money going into this special needs trust. And like I say, the money in that special needs trust would be there for the disabled beneficiaries' extra and supplemental benefits, okay? Things like clothing needs, things around the room, medical expenses that might not be paid, but there's a whole laundry list. I have sheets and sheets, of things that the money in a special needs trust can be used. And again, the money that's in that special needs trust, because it's not the disabled beneficiary's money, is generally not held against that individual in terms of eligibility. There's times also where we use what are called first-party special needs trusts. So I get involved with situations where, let's say, a person with a disability accidentally inherits some money, from a well-meaning grandparent or an aunt or an uncle or somebody else, okay? So again, the person with a disability who's getting benefits that have asset and income limitation unexpectedly receives money, okay? And what we have to do then is to preserve the benefits for the person with a disability. We have to put that, and they call this a first-party special needs trust. First party meaning it's the money of the disabled beneficiary. But the big difference between the third-party special needs trust and the first-party special needs trust is with the third-party special needs trust, after the disabled beneficiary passes away, that money can go to other family members, other siblings, that type of thing. But when we're using a first-party special needs trust, because basically the state and federal government are allowing us to put that money into a first-party special needs trust to protect benefits. But then the kicker on that is when the disabled beneficiary dies, they have to pay back any Medicaid agency where they may have gotten benefits through their lifetime. Okay. Another area where I practice a lot is, like I say, in the area of guardianships or conservatorships. Here in Illinois, we do call them guardianships. And the purpose of a guardianship is so someone can take control of the disabled beneficiary's, financial finances, so they can take care of their money. And then also the guardian can take care of their person. So with the estate guardianship, guardian of the estate, again, somebody's going to be appointed to take care of the financial affairs for the person with a disability. And as far as the personal affairs are concerned, that'd be like things, making sure they're getting their education, making sure they're getting medical treatment, making sure that their living arrangements are proper. So that's like I say, what the guardian of the person does. Another way to handle that sometimes too is sometimes, we have a very high functioning child with a disability. So we may do what we call powers of attorney. There's a power of attorney for property or for assets, and there's also a power of attorney for healthcare. So a lot of times with a high functioning beneficiary, okay, we will just have them, sign and authorize a parent to be their power of attorney for property. In other words, help them with their financial affairs, and also the power of attorney for healthcare, which allow the parents to participate in healthcare decisions so they can talk to the doctors in the hospitals and find out what's going on. Another area where there's been some movement in the last 5 or 6 or 7 years is what they call supportive decision making. So it's not a court ordered system like with a guardianship where you're going through the court system. It's in a sense sort of like a little bit the powers of attorney for property and powers of attorney for healthcare. But the supportive decision-making agreement is an agreement between the disabled person and maybe a parent or some other family member, or it could be someone else altogether. But basically what that allows the person to do is to help the person with a disability, make decisions. So again, it's very important for you as a parent of a child with disabilities is to get your estate plan in place, because I've been involved in situations where the parents didn't get anything in place, and we were, struggling to get things done after the parent dies, once that person with a disability has already inherited something. There's another thing that we also use, I guess I'll say another tool that we also use in estate planning for parents of children with disabilities, and it's called an ABLE account. It stands for Achieving Better Life Experience, ABLE. And most states, in most states, you'll have access to an ABLE account. Here in Illinois, we have an ABLE account. We actually have a statute on it too, and that's handled by our Illinois Treasurer. And so we set those up regularly, and what we have to do is we have to make the application online at the Illinois Treasurer's office. We have to have them approve it, and then they, the family can put up to $18,000 a year into that ABLE account, and the money in that ABLE account can be used for what they call the qualified disability expenses of the person with a disability. And qualified disability expenses, you can actually use the money in that ABLE account to pay for things like rent and food and things like that, which would normally negatively affect a disabled person's right to receive SSI or Medicaid. So an ABLE account has become a very useful tool for special needs planners. So again, I'm going to encourage you today, if you don't have an estate plan in place, to call an attorney, find an attorney who can do a special needs trust or do this planning for you, okay? And I'll be willing to answer questions, and I know at the end of this we'll have questions, and I'll be happy to help you with any questions you may have. So that's my presentation. And again, I want to thank the Epilepsy Advocacy Network and Carrie and Erica for being able to present to you today. Thank you.
Thank you, Mike. Next, we would like to welcome Jen Griffin and Tracy Dixon Salazar from the LGS Foundation. They'll be sharing their perspectives as parents with experience in transition of care. Thanks for being here, Tracy and Jen.
Hi, I'm Jennifer Griffin, and I am the Director of Family Support for the LGS Foundation, and I am the mother of Theo, who is 22 years old, and he has LGS, which is Lennox-Gastaut syndrome.
Hi, I'm Tracy Dixon Salazar. I'm the executive director of the LGS Foundation, and I am mom to Savannah, who is 31, who has Lennox-Gastaut syndrome.
So we're going to talk to you today about our experiences with our kids during their transition to adulthood. And Theo, my son, I'm going to start because he's younger and we've just been through it. He just turned 22 years old. But I would say that our whole transition process began when he was about 13 or 14 years old. I was working for an organization that had day programs for adults with disabilities. And it was a beautiful day program. So I thought, okay, I'm going to get Theo on their waiting list at the age of 14. And so he's been on that waiting list since 14, and he just turned 22, and he aged out of the school system. And believe it or not, he's still on the waiting list. And that is for multiple reasons, not the least of which is the level of severity of his needs. Lennox-Gastaut syndrome is really quite catastrophic. It's one of the DEEs and developmental epileptic encephalopathies. And Theo is nonverbal. He is a wheelchair user. He requires assistance with all of his activities of daily living. And because of that, Theo probably requires one-to-one care. And a lot of these day programs, they are understaffed. And of course, the staff that they do have is not very well trained. So he cannot be in an environment that it requires, like 4-to-1. Theo needs to have 1-to-1. He also has seizures all the time, so every day. And so he'll need to have a staff that is comfortable in handling those seizures and managing whatever it is they have to manage. So this has been, this is now a problem that has always been something we've looked to in the future, and now the future is here. With regard to his medical care, we started that whole process as well. As soon as he turned 18, we got him conserved. And his conservatorship, came at a cost, first of all, which is something that not all families are able to do. And it was really hard for us to come up with that money. But I'm glad we did, because he required a surgery not long after we did the conservatorship. And really, as they were prepping him for surgery, somebody from the admin office came up and said, "Oh, by the way, do you have conservatorship documents for this nonverbal person who cannot give permission for surgery?" And we had the paperwork with us, so we were able to continue with the surgery. But imagine if we wouldn't have been able to do that. So that was something that we required right away. We also got SSI for him, and that took 2 years for us to get. And the big surprise came when he was just after he turned 18, and his epileptologist, who had told us that, Theo would be able to stay with her well into adulthood, she had a life situation that made her rethink her future, and she decided to scale back her practice. And Theo was no longer going to be able to, she was going to get rid of all of her adult patients. So we had to look for an adult epileptologist. She made a referral, and that's great. But, the new doctor is a very nice guy, but he only gives us 15 minutes. And it's not that warm, fuzzy feeling when your child is in, the pediatric care. And it's not family-centered, it's patient-centered. But really, it's still the family that is in charge, because my son is nonverbal and he cannot tell the doctor how he's feeling, if he's depressed or, any of the things that doctors ask their patients. That's really up to me to still report back to the doctor on. So, it's been a bit of an ordeal in the last few years. How about you, Tracy? You've been doing it for a little while. So how's your experience with Savannah been?
Yeah, I mean, it's interesting because when we think of transition of care, you often think of transition of medical care, but you're right. There are so many of these different levels, started with the transition out of the school and into the world, right? Where you just sort of cut off at 22 years old, and you're supposed to find a program. We did get a conservatorship, and we didn't have the money to pay for it, but they did, the local regional center had a template of what, you know, the 57 legal forms looked like that and what they were supposed to look like when you filled them out. So we downloaded them all and then copied and pasted it over. So I was essentially filling out these really complicated legal documents with a model, and ultimately got her conserved. Savannah is, she is verbal, and she does need assistance with her daily skills, but she can, you know, toilet herself with reminders. She needs, but she functions at about, you know, a 5 to 6 year old level. And when you have this trifecta of, you know, seizures that are coming, you know, daily or weekly, a lot of seizures, and you have this severe intellectual disability, right? Where they're like a 5-year-old mentally, or even an infant mentally in many cases with LGS. And then you also have these behaviors, and whether those behaviors are because they're mentally acting like a 1-year-old or because they are having aggression or autistic features, right? When you mix those three things together, there's not a lot of places for these loved ones to go. And that's really what we found with Savannah when we left school, was they're like, okay, we have these 3 different programs that she can go into, and none of them were appropriate. You know, the seizure, oh, we'll take her, you know, for her behaviors and her intellectual disability here, but no, she can't come if she has seizures because we can't manage that. Or over here, we could take them for seizures, but why? But she has to be able to toilet herself. Clearly, she's not going to get that kind of support. So after school, we started plugging her into like Special Olympics and to the different therapies, therapeutic riding and our different therapies. And we started going to church. We started trying to spend more time with family and friends. And just over time, you know, we've either been asked to leave those programs or not made to feel welcome anymore because of that trifecta of features, right? You know, Special Olympics, they asked her to leave because she wasn't listening. Well, she is a great listener, but she didn't understand, right? And there's a difference there. And so Savannah's world has just been getting smaller and smaller and smaller. And then when COVID hit, I think all of our worlds became very small, and it was just our home. And while those of us are kind of coming back and being more out there, Savannah's world isn't getting any bigger. So we've really started thinking about creating like a home base for her here. And when I think, you know, and there's another element of transition, which is the medical transition, but there's also sort of this aging adult transition that you have to go into. And we're creating this home base for her where people come in and visit her, or maybe therapy comes in. And I feel like all of this that we've learned about the transitions, you know, transition from school to adult, transition in the medical community, transition to an aging adult, have been word of mouth, right? There's no systematic way for us to learn about these things. And that's why I think Jen and I both work at the LGS Foundation, is that we've been there, done that, and we can share what we've learned with others. And, you know, we have a 12,000 member community that's constantly sharing, but we're also creating all of these educational resources. You know, and then finally, you know, there's the transition of medical care, and that she's 31, and I don't think we've transitioned, actually. I think we're still trying. We've seen over 10 epileptologists that are adult care providers. And so after school, we moved to Chicago for 2 years, and we saw several providers there. And we finally, on the 4th person, found somebody that understood what we needed. And then we moved back to San Diego, where we live now, and I've tried a bunch of them. But I think one of the biggest issues, in addition to them, you know, going on vacation and there's no coverage, we can't get an appointment, so we can only see them for every 7 months, is we don't get sort of that holistic care that we got when we were in pediatrics, right? So you know, in pediatrics, they're trained as pediatricians in the whole child. So sleep, behavior, mobility, you know, and the neurological condition are all integrated. And she's certainly on meds for so many different things. But in adult care, it's all separate. Go to your sleep specialist, go to your neurologist, go to your, you know, your mobility specialist, and you're the quarterback, even more so than you were in pediatrics. And in addition to that, you know, when LGS, the nature of LGS is that seizures just spike, you know, and for no reason. All of a sudden, I mean, I'm sure there's a reason, but we don't know it. And in pediatrics, they would do medication management, where within 24 hours, you'd get, a doctor would say, okay, we're going to go up on this meds, we're going to go down on this meds, and, you know, check back in with me in the EHR. The plan in adult care is that we go to the emergency room, and then the emergency room is going to rule out, you know, an infection. It's going to rule out, you know, a brain bleed. They're going to do a CT scan. They're going to run all these labs. They're going to check her blood levels. And in theory, that seems great. But if a patient is having 3 spikes and seizures a month, it's unrealistic. And the nature of the disease is not understood well enough to know that the going to the ER between visits is not really a sustainable plan. So I think that we still haven't transitioned. I'd be hard pressed to find an adult, a caregiver of an adult who really felt like the transition was easy. So that we at the foundation are really trying to make it easier for families who can learn from us as we share our stories.
Well, obviously, I have a lot to either look forward to or be afraid of. But you and I both have obviously some very different experiences and very similar ones as well. So there's a lot to this whole transition process. Thanks.
Thanks, Tracy and Jen. Jen and Tracy have even more to share with us, and we'll now be discussing self-care tips for the lifelong caregiver. Thank you both.
Hi, so Tracy and I are back, and now we're going to talk to you a little bit about self-care. And this is something that comes up quite a lot in our community. Self-care is maybe a bit of a triggering topic for a lot of our families because, if you say to somebody, well, are you making sure you take care of yourself? It just sounds like another chore. It just sounds like another thing that you're asking me to do that I'm probably going to fail at. And also, I don't feel like I deserve self-care because my child is seizing every day, all the time, has behaviors, nobody sleeps. We have all these other issues that we're dealing with. And so who has time for self-care? And of course, a lot of us, I think when we think of self-care, we think of, going on a cruise or going out for, date night with our husbands or partners. And that is self-care, but we don't think small very often. And maybe we need to think of where are the moments in our day where we can just take some time to give to ourselves just a little something. And just think of what you do every morning. You wake up, you have a cup of tea, a cup of coffee, if you send your kids off to school and you take, a few minutes to just listen to a piece of music, or even the time that you're spent in the car driving them to and from, if you're listening to some great music, something that just makes you feel part of the world instead of part of the war that you're living, that can be great. So think of little things like a glass of wine at the end of the day or a cup of tea. After my son goes to bed, and because of a lot of his medications, he actually falls asleep kind of early, but he also wakes up a lot during the night, and he also wakes up really early in the morning for good. So I could go to sleep, and I probably should, but I don't. I take that time to sit down with a glass of wine or a cup of tea and a bag of chips. There's always a bag of chips involved. And I love to binge watch something. I love to stream a good TV show. And that to me is a little bit of something for me. And I don't need anybody to criticize my taste in TV shows because I have no time for that. I am just going to enjoy my TV show. Now, I used to love to read, but because I don't sleep very well and because I, for, I don't know, many reasons, I just, I can only do Audible now. So for a while, for a few years, I didn't read because I would fall asleep. And now I take my son for a long walk. I'll put him in his wheelchair about 4 or 5 times a week. I will just put him in his chair, and I live right by a bike path, and we'll take an hour-long walk, hour and a half, and he's happy. So I'm feeling like I'm doing something for him. But at the same time, I'm doing something for me too. I've got my little book in my ear, and I'm completely enjoying my, whatever it is I'm wrapped up in. So that feels like something a little decadent, or just if you want to open a bag of cookies at the end of the day and just indulge, by all means do that. I don't think that we sometimes don't take good care of our own health, so we have to do that. But, chatting with a friend or treating yourself to a little something. My friend community is tight, and I have these 4 girlfriends, and one time I said to one of them, I forgot to get milk and bread at the grocery store. And she just lit up and she said, oh my gosh, that's what I can do for you. I can actually, go to the grocery store, and if I'm out there, I'll just text you and say, do you need anything? And I can pick it up and run it over to you. And I realized that that was important to her because she feels like she feels helpless and how to help me and my son. And now she has a way that she can just help me. And I told her that you have to promise to take money, because in the beginning she was like, it's just a couple of things, don't worry about it. And I said, no, if you're not going to take the money, then I'm not going to ask. I'm not going to let you do this for me. So we have an agreement. I give her the list. She picks up stuff and then she delivers it to my house. And she lives like 10 minutes from me. But the ultimate self-care that I think that needs to be pointed out is we have a private online Facebook community, and there are over 7,000 members in that group. And so many people have said when they discovered that group that it has been life-changing for them, because they're talking to another parent who gets it, another caregiver. So please find your community. I think that is the ultimate in self-care. What about you, Tracy? What is your self-care secret?
Yeah, I remember when we brought self-care to our community for the first time, and it was not well received. I mean, I think, when with Lennox-Gastaut, it's a very severe epilepsy syndrome, right? And we're dealing with life and death a lot, right? I feel like that's what we do. And if it's not life and death, then we're dealing with things like feeding and toileting and, taking medicine, right? Like just things to keep this person from going into another crisis, right? And and I think I think you're right. I think the reason that the community didn't react to it well, and the reason that I never reacted to it well, was because it was too big. You think about, going to the spa. Like none of us are going to the spa. We have a sick kid, right? And it's all hands on deck over here. And so I think, making it smaller. So for me, it's my coffee first thing in the morning. I just want to drink my coffee or my tea and think of nothing and do nothing, just that quiet time, and not feeling guilty in the morning that I'm taking that time for myself. That is self-care, and I think also for me, I love audiobooks, right? And I love fiction that's going to take me to another world. The more dragons, the more vampires, the better, because I don't want to think about real life, because our real lives are really, really devastating. Our kids are very, very sick. I think also when you think about self-care, you have to think about it in the long term. Initially when Savannah first got sick and about a year in the journey, I became very depressed and I went to a very, very dark place. And thankfully I I got counseling. And then I also, went on some anti-seizure medicine or some antidepressants. I got seizures on my brain, but some antidepressants, and I climbed out of that hole. Right. And I am not going back. If I catch myself sort of falling down that spiral again, and it's very tied to how well my daughter's doing, I do take the steps that I need to. I go outside, I go see a friend, I go for a walk, I watch a movie, right? I do something to get me out of it. But I also think you have to look long-term, right? Because, we co-sleep. So Savannah sleeps in our room with us because we've had incidents where she stopped breathing in the middle of the night because of her seizures. And that's the choice we've made, but none of us sleep very well. And now that I'm in my 50s, I'm starting to experience a lot of health issues, right? Because of lack of sleep, because of poor diet. And so about a year ago, when the doctor was like, hey, your cholesterol's creeping up, hey, you need to lose a few pounds, the things that all of us, get told, we started to pivot our lifestyle, and just one small change at a time. Hey, we're just going to plan out lunches. We're going to pre-make lunches, on Sunday, and we'll make something so that we know that at lunchtime, we're not scarfing a hot dog and, chips and a couple of pieces of candy because that's all we had, right? Like we're really planning out a healthy, we love like chili and soup and things. So we make a big pot on Sunday and then we packaged it for the week. And so just one small change. And if we succeed in that once, we've succeeded. Right? It's not this like massive lifestyle change. And what we've noticed that as we do this more and more, we're starting to develop habits. Our brain is mapping out new, neural networks, and we're getting healthier about eating. We have more healthy options, and, my weight's coming down and my blood pressure's coming down. Right. And so you have to think in the long term, and it's not selfish to do those things. Right. I mean, and don't get me wrong, I indulge on chips and cookies. That's not the problem over here. But when you take these moments for yourself, you're actually going to be a better caregiver. And it is hard to think about self-care because it is so taxing to be a caregiver. But one quote that's always resonated with me is that make time for health or you will make time for disease. And I think that's what's happened in my family. And thankfully, we've caught it early enough and we've been dedicated enough to kind of flip it and reverse it. You know, she's eating like a queen, right? You know, I'm making all this really healthy food for her, but then over here, you know, I'm scarfing, you know, fast food and eating cereal at 9 o'clock at night, right? And that's not going to ensure that I'm here in the long run to take care of her. So it's really important to prioritize it. It's really important for Jen said to find your community. I'd be lost without our caregiver community of people who have been there, done that. And then my friend circle is not as like big and solid as Jen's, but my family, me and my husband and my son, like we are really connected and really close and we really support each other. So having all of that is self-care. And the trick is not feeling bad about it. And the trick is carving out time, because if you don't carve out time, you're going to be scarfing cereal at 9 o'clock at night because you didn't plan, but it's okay to carve some time for you.
Awesome. That is so great, Tracy. I'm so glad that you mentioned mental health as well, because that is something that, you know, that we have to really be mindful of. And I think that it impacts us. There are a lot of people that are struggling in our community. So, you know, hopefully there are people that are not in those dark places, but if they are, that they're going to learn these tools, and, you know, take these tips and get better earlier so that they're not struggling so much in those early days as you and I did. Thanks, everybody.
I just want to say thank you once again to all these speakers. Even though I got to talk with them and hear a little bit from them before this, it's just still amazing to hear the expertise of our speakers. Jen and Tracy, I just think the way you share your stories without sugarcoating, but it's still hopeful. It's just amazing. And I think that's so impactful for the folks who have been on the call tonight or who will watch this recording when it gets posted. We do want to open it up for our question and answer now. I'm sure we've got a couple that I know were for Mr. Gulo here on the legal side of things that were already in the question and answer box. But we're going to bring up all the panelists and allow you guys to put any more of the questions that came up while we were listening and learning from these awesome speakers that we've got. And I think Lisa and Cassie are going to help with the fielding of the questions.
We can do that. And I will say to the participants too, if you don't put a question in the box, you can also raise your hand and we can call on you that way as well. Do you want me to read it, Carrie, or are you going to read it?
I can read the ones that are already up here. So for Mike, a couple of things that came up while you were speaking. So one is about the trust. So can you choose whether the money goes into a first or third party special needs trust? And I believe you're muted still, Mike. Sorry.
Typically, the difference between a third-party special needs trust and a first-party special needs trust is this, okay? With a third-party special needs trust, the money going into that trust is coming from a third party, okay? Typically a parent in their estate plan, sometimes grandparents, sometimes other family members, okay? So again, the money would go into that third-party special needs trust from someone other than the person with the disability, okay? During the lifetime of the person with a disability who's the beneficiary of that trust, the assets in that trust would be there for that beneficiary is what we call extra and supplemental benefits, okay? Then upon the death of the person with a disability, that money can go to, you know, other children or charities or someone else, okay? So typically, again, with a third-party special needs trust, the money's going in there comes from a third party, okay? With the first-party special needs trust, generally the money going in there belongs to the person with the disability themselves. An unexpected inheritance, maybe they've had an accident, are going to get a $50,000 or $100,000 in, you know, for a recovery in an accident, some kind of a settlement. Okay. And what you're doing there is you're putting that money into the first party special needs trust to protect that disabled beneficiary's benefits, such as SSI that has asset and income limitations, Medicaid, public aid, food stamps, you know, home care, those type of things. Okay. And the main difference is with the first party special needs trust, when that beneficiary passes away, you have to get a hold of your state Medicaid agency. And of course, sometimes you're dealing with a couple of different state Medicaid agencies because the person might have received benefits in a couple of different states, but the money in that trust has to be used to pay back that state Medicaid agency. So as a parent, you want to use the third party special needs trust. Okay. The first party special needs trust would just be a tool to protect the disabled person's own money that they unexpectedly receive because of an unexpected inheritance or you know, settlement from a car accident or something like that. Okay. So as a parent, you always want to be thinking the third party special needs trust.
Awesome. Thank you. And another one that came up during your talk, Mike, and you had mentioned the Special Needs Alliance. So
Correct.
someone asked if there was a good place to find an attorney that can help in Florida. So is that?
There's a lot of Special Needs Alliance members in Florida. So if you go to the Special Needs Alliance website, there is a button to click, you know, a drop-down menu where you can find an attorney in your area. And I know there's attorneys in the Miami area who are a member of the Special Needs Alliance. There's attorneys in the Tampa area, on both coasts. Not sure about the Panhandle, okay? But yeah, there are a number of Special Needs Alliance members who live in Florida. And again, you can just go to the Special Needs Alliance website and, you know, start looking.
That's great. A question for Megan. Is there any benefit between going in person to do some of these applications versus online, or is it really equal?
So most times appointments, if they're not done on the application's not done online, it's going to be a phone appointment. There's not too many in-office appointments anymore. There are times we set them up if there's limitations to phone, you know, ability to use phones, but the majority of the time it's going to be on the phone. So in my opinion, if you're able to do the online application, what I've noticed is we tend to get more details on those. So sometimes when someone's on the phone, they kind of want to get off the phone, right? You know, it's like, oh, okay, let's get this over with. So shorter answers, shorter descriptions. And then when we get a product that's been submitted online, they've been sitting at home, you know, they're not getting interrupted, or if they are getting interrupted, they can kind of pause it and go back to it. And then, so we'll have maybe a whole paragraph about not just the name of the condition, but the limitations of the condition that kind of give a bigger picture. So that is one thing I will say I did notice of the differences between the two. Now, if you're filing for somebody who's 18, you can actually file the online application as a third party. That will get around having to create an online My Social Security account. And then the application will just have to be sent out for a signature or an X with witnesses if the person you applied for isn't able to sign their name before we can send it off for processing. But that would allow, you know, a parent as the third party member of an 18-year-old to apply and do the application online.
Awesome. It's good to get your perspective on that. Thank you.
Mm-hmm.
This one I'm thinking is probably going to go to Mike again, but it might be something that others have something to chime in with as well. My oldest is turning 18 and has epilepsy. She's able to make her own medical decisions, but mom is still going to have access to her My Chart. If she would be incapacitated or wind up in the hospital, does she need to have something in place to make decisions for her? Yeah, go ahead.
Probably what I would recommend in those circumstances, in Illinois, we call them Illinois statutory powers of attorney for property or Illinois statutory powers of attorney for healthcare. Okay, so if the now adult child can make their own decisions, I would probably say so a parent can be involved. The best thing to do would be to have the child do a power of attorney for healthcare, appointing the parent as the person who can be involved in healthcare decisions, talk to the doctors, talk to the hospitals, get medical records from the doctors and the hospitals, on behalf of the child, the adult child with disability. Okay, so I think under those circumstances, probably a power of attorney for healthcare would be the thing. And most states are going to have them. They might call them a little bit something different. Okay, but in Illinois, we do call them the power of attorney for healthcare. So that's probably what I would be advising that person to get for their daughter with adult daughter with a disability.
Thanks again, Mike. This one I think I'll first direct to Dr. Issa, but if anybody else has something to chime in with, you shared some of those resources about transitioning care. Did those cover mainly medical, or did those have some of the holistic things like that Jen and Tracy brought up included on them?
Yeah, because it was created by the Child Neurology Foundation, and I sort of echo the comments that Jen and Tracy made, that there really is a culture difference from being in a pediatric environment to an adult environment. Even as the adult epileptologist, I always feel guilty about that, but it's true. So they actually do have a lot of, those resources have a lot of documentation and a lot of kind of guideposts for different transitions, not just the medical decision-making components of it. So yeah, I think it's a good place to look as you're sort of thinking about planning in different domains, among them legal and medical and so on.
And I know you had those up during your presentation, but can you name, there was the Child Neurology Foundation and then the other one that you had up there in case people want to search them?
Let me see if I can get those links here.
Thank you. Well, he's doing that. Have I missed any other questions that came up that anybody sees, Lisa? Or
I'm not seeing anything else in the chat or any hands up. And Dr. Issa, thank you for putting the links in the chat.
perfect.
Looks like you got them better than I did. That's good.
Then I suppose, do any of the panelists have any final thoughts to share? I think this has been a really educational. It's a tough topic, but I think you all presented it in an uplifting way as well. And knowing that there's that community of support out there, and sometimes we just need to go and look for it and find that support that we need, and find those little things that are self-care that aren't too difficult to obtain, like Tracy and Jen talked about, but making sure that we do still make time for that. But I did want to open it up if any of you had any final things to share before we wrap up tonight.
I'm actually going to ask Jen and Tracy a question. If there were two things that you would tell an adult epileptologist, what do you want us to know? Because it's rare that we actually get you guys talking to us directly. And what perspective should we hear?
I'd love to see, I know our own experience, and I'm happy with the doctor that we have, but I felt like when we showed up for our first appointment, he was just kind of asking us, well, what do you want? And I feel like you have to maybe start all over again. I'd love to start all over again. Like, what labs need to be done, review our chart, look at everything that we're doing, and say, okay, have you, just check in with us and say, have you tried this, and this? Because it's worth revisiting. And we're not just in this sort of maintenance space. We're always looking forward. We're always, I think, I'm always looking for new treatments and new ideas. And I'm just not, I don't want to just maintain.
Yeah, I appreciate that question very much. I think one thing that would be really helpful is to understand how medication management works in the pediatric setting. And I don't know if you guys have that kind of support in adult care, but usually I could call up the pediatric epileptologist or neurologist, and then within 24 to 48 hours, we've done a med change, because going to the ER isn't really, the ER doesn't want it. We don't want it. You don't really want it. You think you want it as a provider. So I think that would be one thing. I think another thing that would be really helpful is to understand that when we get sent out to GI, or we get sent out to psych for behavior, we get sent out to other specialty, they're really afraid of the, or unfamiliar is maybe a better word, they're not afraid of the anti-seizure drugs that our kids are on, and of upsetting the balance. And so we end up trying to play quarterback between all of that. And it's really challenging, I think, to try to get you, even if you're at the same hospital, sometimes it's really hard to get you guys to talk. And then finally, I would just say, wanting to work with our loved ones and not giving up. Like, we don't have the luxury of giving up on our loved ones, but I think that it can be really depressing when the kids don't get better from seizures. But really all we want is somebody that's not going to give up and that actually wants to be there.
You made me think of one more thing too, which is just the you're really still treating the whole family, because the whole family is still impacted. And a lot of our, like, I know with my own son, he's not able to speak on his own behalf. And it is probably, if it's feasible, to see how that is impacting. Like, you heard Tracy and I talk about how, the mental health of the caregiver continues to be fragile. And especially now as they're getting older, we're hearing a lot from our caregivers of older children who are in their 30s and 40s. Some of them, they're very, very concerned about how they're regressing and how they're getting worse. And they're also worried about, where is the care for them after we can no longer care for them.
Yeah, I think when I sort of alluded to this one in the talk, but I see a lot of families coming in and they've been working very hard to keep things going. And I'm looking and I'm thinking, one diagnosis in the parent and all of this work falls away.
Yeah.
So I really like to emphasize, okay, what's your plan for, might happen tomorrow, but think about it as, what's your plan for 5 or 10 years from now when you might not be as capable? So I think that's something that's really hard to think about. I see some parents, and in particular moms, because moms take so much of this on, but not always moms, but particularly moms. Sometimes the level of sacrifice and care is so almost, I hate to say extreme, but it's just so big. Sometimes that child will only respond somehow to the mom or to the dad, and suddenly there is nothing else that can exist. And I don't know how these sort of self-care things, but sometimes we have to also say, okay, you have to have some priority in the world, and it's okay for you to have some priority in the world.
I wouldn't be doing my job if I didn't also suggest that you refer them to their patient advocacy organization, because they need to have their community and our families. Time and again, we hear it, that it's been life-changing when they're connected with us, because they don't feel because they're so isolated. They're
I think that's a very,
very
very
isolated.
And I would just add one more thing. This is an area that we've really been working on at the foundation as well. And, transition of care for one of the severe epilepsies can be really challenging. So we do have something on the LGS Foundation website called our Adult Care Binder. And it's out of control. It's like a really comprehensive binder. And if you're going through transition right now, like a lot of the stuff that was talked about here is in there, you're going to read it cover to cover. But if you're just like approaching it, you're going to be overwhelmed. And so we're trying to kind of break it up into little pieces and spread it out. But it's free. People are welcome to grab it. And it talks a lot. It was created by caregivers for caregivers. And part of it is that exact thing, that it's okay to acknowledge that you need self-care too. And it's okay to acknowledge that you might not be here forever. It's like our worst fear and our biggest hope is combined, and it's horrible. It's like, we don't want them to outlive us because No one's going to care for them the way we do, but we don't want to bury them either, right? And there's a certain point in the journey where you sort of are faced with that. And if you can be surrounded by other people when you are faced with that, especially if they are really dependent on you, then you can get some guidance on how other people have gone through it.
There was one thing I heard from a fellow member of the Special Needs Alliance who has a child with a disability, and he said, you know, it's a parent's hope they live one more day than their child with a disability.
Yeah.
Yep.
Same minute. Can we just like die at the same exact second? That'll be perfect. Is that allowable?
Yeah. It's true.
Wow.
Thank you guys a lot for that discussion as well. And I think that is a great kind of segue into sharing that we do hope that everybody on this call will look into their local organizations. LGS Foundation is also an EAA member. You've got us in Illinois, and there are other organizations throughout the country. Don't go through it alone. Find that support. And again, we thank all the speakers tonight. We thank you guys for all you brought and educated us with. And if anybody on the call does have questions that come up afterward, I'm sure we'll be happy to respond as we're able. So anything else, Lisa, before we close?
I think that's it. I just want to again thank all of our speakers and thank Carrie and Erica for helping us to put this together from Epilepsy Advocacy Network. It's a great collaboration in the community, and we want to thank everybody for their time tonight. We will put the recordings up on the site by presentation so that you can revisit them. So
Thanks for
thank
having
you.
us.
Thank you.
Thank you, everyone.
Have a
Dr.
good night or
Mike Google,
afternoon wherever you are.
Lisa, Tracy, Jennifer, everyone. Thank you very much.
Bye-bye.
Bye-bye. Good night.